Thank you very much. Today, our topic of discussion is integrate CTO techniques. I am Dr. Mohammad Wakas, working as a fellow DCB Academy under proctorship of Professor Bernardo Cortese. As you know that chronic total occlusions are completely occluded coronary arteries with thrombolysis in myocardial infarction, zero flow with an estimated duration of at least 3 months or more. What is the international data behind the opening of the CTO, chronically obstructed arteries? First of all, starting with a multi-center trial, this is a Euro-CTO trial. It evaluates the utilization of revascularization or optimal medical treatment for the treatment of chronic total occlusions. It randomly assigned 396 patients in which CTO PCI versus optimal medical therapy alone. At 12 months of follow-up, this trial proved that patients randomly assigned to CTO-PCI had greater improvement in angina frequency and quality of life according to as assessed with the CTEL Anginal Questionnaire. Moving forward, there is another trial, which is an Impactor CTO trial. This is a single-centered trial, and it evaluates the inducible myocardial ischemia of percutaneous coronary intervention versus medical therapy in patients with right coronary artery chronic total occlusion. It randomly assigned the 94 patients with isolated RCA CTO to CTO PCI versus optimal medical therapy. At 12 months of follow-up, this trial proved that patient undergoing CTO PCI has a greater reduction in ischemic burden and improvement in 6-minute walk distance and quality of life as assessed by the short form 36 health survey. There are certain other trials in which in the same CTO trial, like there is no symptomatic benefits were observed in this trial. However, this study enrolled patients with minimum symptoms and crossover rates were high in both treatment arms, moving the outcomes toward the null. In observational studies, CTO-PCI relieved regional ischemia, improved the exercise capacity, and increased anaerobic threshold with improvement in the depression. On the other way around, there is a viable myocardium supplied by a CTO. It is a persistently ischemic zone, and it remains undetermined whether CTO-PCI improved cardiovascular outcomes such as left ventricular ejection fraction, risk for arrhythmia, and mortality. So, although CTO-PCI may improve the heart outcome, but this is there is one thing which is very important, which is a large ischemic burden, ischemia of more than 10% of the myocardium whom revascularization is achieved. This hypothesis will require confirmation in well-designed prospective randomized controlled trials such as ongoing ischemia CTO trial and novel CTO study. Now, the most latest we have it is a Euro CTO at 3 years of follow-up.
Yeah, Wakas, sorry, excuse me.
Yeah.
But this presentation was on antegrade CTO technique. It wasn't on the literature about CTO. So since you only have 15 minutes, I don't know if you want to concentrate 1/3 of the time or half of it on literature data which are off topic.
Yeah, Professor. Yeah, I'm just, this is just a short and just moving forward in a rapid.
Yeah, but you only have 15 minutes, because during these lessons, you only have 15 minutes. So remind that.
Yeah.
Okay.
Yeah. Thank you. I'm just. This is the latest Euro CTO at 3 years. It compares the outcome of PCI plus optimal medical treatment compared to optimal medical treatment alone for the treatment of chronic CTO, and it concluded that there is no difference in the 3 years in the 3-year incidence of cardiovascular death or myocardial infarction between the PCI plus optimal medical treatment and optimal medical treatment alone. So what is the guideline? Guideline is, it is now, previously it was 2A, now it is declined towards 2B on the basis of Explore and REVEST trial. And this trial did not demonstrate any improvement in the ventricular function with CTO-PCI versus optimal medical treatment. So the benefit of PCI of a CTO to improve symptoms is still uncertain. Now moving forward to our discussion, this is what are the basic prerequisites. We are generally following the algorithms. In this algorithm, we are using the hybrid algorithm like a dual injection. In dual injection, We engage both on right and left coronary arteries, and we and define the anatomy of the CTO, including the proximal cap, poor distal target, appropriate intervention collateral, and if there is if these all above are not present, then we proceed forward with the antegrade techniques. Antegrade techniques, there are two different techniques. This is an antegrade wire escalation and antegrade dissection and re-entry. If the lesion length is less than 20 millimeter, we proceed with the antegrade wire escalation. And if the lesion length is more than 20 less than 20 more than 20 millimeter, then we move with the antegrade dissection and re-entry technique. And with antegrade dissection and re-entry technique, there are two wire-based techniques. These are the last and the star technique, and one is the very most recent is a control technique, which is a stingray cross-post technique. And if the this fail, then if the above is present, then we start from the retrograde with retrograde wire escalation and retrograde dissection and re-entry.
Yeah, show us how they work.
Yeah. There is one important point which I just want to highlight here. Consider CTO-PCI failure in the following condition unless the procedure is well advanced. That is, the procedure time more than 3 hours, contrast load more than 3 hours, contrast load more than 4 into estimated GFR, and radiation dose more than 5 Garai. This is the point when we need to stop the procedure. So dual angiography is very important. It is used to improve the technical success and reducing the complication of CTO-PCI simultaneously with dual coronary angiography. Dual coronary angiography allows better visualization and understanding of CTO anatomy, complexity of the lesion, and likelihood of success. And there's another technique, which is a ping pong technique. The use of two catheters in the left main coronary artery will allow for easier guide wire and microcatheter management, especially when using a retrograde approach. So while defining the anatomy, we need to see the proximal cap. We need to see the lesion length, course, and composition, is distal and distal vessel, and the collaterals. There are certain CTO scores. Mostly we are using the JCTO score, which is very well established score, and it identified a successful antegrade guide wire crossing within the 30 minutes. Based on the 5 criteria, at least one bend of greater than 45 degrees in the CTO anatomy, occlusion length more than 20 millimeter, calcification, blunt proximal cap, and previously failed attempt. Other scores are the Progress CTO, CL score, Aura Castor score, and nowadays people are using CT-based CTO score, CT-guided JCTO score, and CT-guided CT reactor score. So as you see in this picture, that there is a CTO technique, which is the antegrade wire escalation. Antegrade wire escalation means that the wire from the true lumen to true lumen. This is the antegrade wiring, antegrade wire escalation. And what about that antegrade dissection and re-entry is that wire is in the subintimal space and then re-enter into the true lumen. This is the antegrade dissection and re-entry. And on the other hand, similarly, retrograde wire escalation, same, from the opposite side of the contralateral side. And we are doing,
yeah, but the retrograde will be assessed in another lesson. So I wanted to ask to explain how does it work, the star technique, and which is the difference between a star technique and a mini star.
Yeah. So this is the you want to go to that ADR or integrate, because this is the integrate. Starting from the ADR integrate, then I will go move forward.
You want to, okay? You want to go for wire escalation first? It's okay.
Yeah.
But so I wanted to, to let you know that the time is passing. So I would like you to finish your presentation with all of the topics.
Okay.
Please.
This is the antegrade dissection and re-entry. For antegrade dissection and re-entry, we need to have different techniques, like the wire in the subintimal space, followed by re-entry into the distal lumen. The star technique is a wire-based technique. It is a subintimal tracking and re-entry. This involves the pushing a looped or knuckled guide wire, usually polymer jacketed wire, within the CTO body until it re-entered the distal true lumen.
Okay, so this is an important point. So which is your preferred guide wire for the star technique?
Initially, my preferred guide wire is I start with the filter XTA, and then if XTA failed while in the subintimal space, then I took the if the CTO body, distal CTO body is very well defined, then I took the Gaia series, Gaia second or Gaia third. And if the CTO body, distal track is not very much well identified, then
Excuse me.
switch to mostly.
I beg your pardon. I have an urgency. Give me a second. Sorry.
Yeah, yeah.
Hello.
Hello. Hello. Sorry. Can you hear me? Hello.
Yes.
Yeah. Sorry, I
Yes.
had an urgency, so I had to respond to a call. So, okay, let's go ahead. Vakas, are you still there?
Yeah, I'm still there.
Okay. So you were saying that you use, but what is strange, for knuckling the wire, you cannot use a Gaia. You have to use a polymer jacket wire. Gaia is really too hard to use. So Fielder XTA is a good choice. If it's not working, you can decide to use a stronger polymer jacket wire. For example, a Gladius or a Rider, maybe from Boston, but or a Pilot 200 for knuckling. But you cannot use a Gaia for this part. Okay, so tell us which is the difference between star and mini star techniques.
In the star technique, all we go with the sometime all we go with the Fielder XTA, but in the star technique, the dissection pack is long. It may prolong, and it sometimes it went into the whole CTO body, and you are entering distally. So uncontrolled re-entry. And when we compare it with a mini star, then mini star is like this, that we are starting like a pilot 200. We have started with once the wire is in the subintimal space, and we don't want to create long subintimal space, don't want to get long re-entry, then we switch to Fielder XTA or Fielder FC at this stage, and just knuckle it and try to enter into the Q lumen. Sometime before mini star, what I am doing is that I used to take a small balloon, just having a fenestration at 6 to 8 atm pressure with the small balloon like 1 or 1.5, and then try to re-enter in a controlled way with the help of Fielder XTA. So sometimes mini star works very good with me when I'm using the balloon for fenestration.
Okay, and when do you adopt the last technique?
Yeah, last technique is also very good. It is like a difference between the wire bend. In star and mini star, I usually try to make two bends. First bend at 1 to 2 millimeter, it is a 30-degree bend, then 15 millimeter bend. And with the help of last, we have a very controlled re-entry into the Q lumen and less intra-plaque course, like a less subintimal course. And I usually take a small one single bend at the wire tip, which is around 1 to 2 millimeter from the tip. It is a 30-degree bend, and no need of second bend in this case. And it works very well with control.
And which wire do you use for the last?
For last, I usually used to take Pilot 200 or sometimes Gaia second.
Well, usually for the last technique, you should use a non-polymer wire, so not a Pilot, but a very hard, cheap wire, meaning Miracle 12, Confianza Pro, Astato 20, one of these, because with the last technique, you have to puncture just after the distal cap. You are still in the subintimal space. You try to puncture the section plan in order to try to re-enter into the true lumen. But to do that, you should use, according to this technique, a non-polymer hard tip guide wire. Okay, please go ahead.
Just quickly, one comment, actually. Can you hear me?
Yeah. Hi, Sandeep.
So if you're using a Stingray, then you use the stiffer wire, because with the Stingray, you're not making any fenestration in the intima. So all you're doing is expanding the space, and then you try to come out. Whereas what I think Vakas is saying is that he does a balloon inflation. I think Carlino does this technique as well. They do a balloon inflation and they cause a fenestration within the intima, into the intima and into the lumen, and then they take all this polymer jacketed wire or something like a more softer wire to catch those
but that's
holes.
that's the mini star. That's the mini star. The last technique, last LAST, is a different technique. So in the last technique, you don't want to create possibly another increase in the length of the dissection plan. And so when you are able to see that you are just after the distal cap, you try to re-enter there. But to do that, it's similar to the Stingray. You know, if you have a Stingray, if you have the money, if you have the device, it's easier because you go there, you place it, you only have to choose which hole is the right one in the right direction. But the concept is the same. With the Stingray, you are more stabilized because you have this balloon, which is a flattened balloon. You inflate it, you stabilize, and then you puncture in front of the dissection plan. So it's I would say that the Stingray is a simplification of the last technique.
Okay.
One thing more, I have seen the Stingray videos but we don't have a Stingray available in our setup. But I will just going forward and we'll discuss further on Stingray.
All right, okay, please.
The unsurprising that long-term results were poor with high rate of repeat revascularization and target vessel occlusion in this case. Now moving forward, last technique is limited anti-grace subintimal tracking wire-based approach to cross the CTO.
We have already said that.
Yeah.
Okay, you can skip this.
Now the cross-post and Stingray system, it is a controlled anti-grade dissection plane to facilitate the target distal vessel re-entry. It is
we have discussed about that. If you have a video on that, we can see that. Yeah. Okay.
This is a Stingray device, cross-post device, and on the basis of cross-post device, first we make a blunt dissection into subintimal space. After entering into subintimal space, we exchange it with a Stingray balloon, and then Stingray wire, then Stingray balloon. Then you use to take the Stingray wire and then exit through the exit pores. These are the two exit pores.
So for those that do not know, crossboss is a device that aims to create a dissection, but it's theoretically a more controlled dissection without the need for creating a knuckle with the guide wire. So with the knuckle, sometimes you cannot control the sides of the distal band. So sometimes it's big, so you create a large dissection plan. With the crossboss, you are able to create a smaller, reduced dissection plan, which theoretically can should create less hematoma and render easier, theoretically, I would say, to re-enter into the true lumen after you have crossed the distal cap. So the crossboss is for the first part of that, or if you don't have the crossboss, you don't want to spend money, you just do knuckle, and then for re-entering, you have the Stingray.
One thing more I just want to add this stage. Nowadays, people are making some modification. They are using a dual lumen microcatheter instead of Stingray system. They are entering into subintimal space with the help of dual lumen catheter. They are trying to re-enter to true lumen. So this is widely now used.
This is true for the recross mostly because that's the only dual lumen microcatheter that has the ability of having two over the wire guide wires. So you put it on your knuckled wire, which is, I would say, more distal. You arrive at the place where you think that you should have crossed the distal cap. So just after the distal cap, and then you try to, you put a second wire and try to re-enter in that place.
So this is the ADR, this is the CTO of the RCA in which the Stingray system has been used. This is a chronic total occlusion of the mid RCA. It is 25 to 30 millimeter in length, CTO body. Initially started with a pilot 200 guide wire advanced into the CTO and beyond the distal cap, but it is in all the way in the subintimal position. Then blunt dissection is not required at this stage because already it is in the subintimal space. So rather the microcatheter advance into the landing zone to facilitate delivery of the Stingray. The Stingray is exchanged into the vessel, inflated and oriented with the target vessel on the left side of the balloon, and final result after successful angiogram. You see that,
this is how it works. I have to say that the Stingray is a little bit bulky as a device, so sometimes you will need to create more room for that. So you knuckle the wire, you try to cross it with the stingray, it doesn't work. You try with a microcatheter first, stingray doesn't cross. So you have to predilate, mostly in long lesions and calcific lesions, calcific CTOs. You have to predilate a little bit outside of the lumen in the area that, in the dissection plan that you have created with the knuckle, and then you will create the room for the stingray so you can advance the stingray after the distal cap and then try to re-enter.
Okay. One thing more I want to just discuss at this stage, that once we are in the subintimal space, then according to data, what is your adaptation? Because sometimes we are very conscious that we don't predilate more in the subintimal space. Just take a small balloon and do the predilatation, or you take a 1:1 balloon, vessel diameter balloon, and just predilate the subintimal space.
You mean before re-entering?
Yeah, yeah.
What? But before re-entering, I also try to, the section plan that I don't like it. So I try to be very conservative. So without also predilating. So use a microcatheter, then try with a mini star if I'm able. If not, we have to convert to, dual lumen microcatheter or a stingray, as we said. And if it doesn't work, you need to create more, space with the balloon, which sometimes, as you said earlier, is also able to do a sort of half reverse cart, so to open the dissection plan into the true lumen only by ballooning. But at that stage, the risk is that you have a large hematoma and you can propagate the dissection too distally. And if this is not very, this is not a big issue in the RCA, unless you have an important right ventricular ramus, it could be a big issue in the LAD, where you have a lot of collateral arising from there. So you should be more conservative in creating large dissection plans in the LAD, in my opinion.
Yeah.
I did not understand the question. What do you mean by ballooning? When do you balloon the subintimal space?
Sometimes my question is that sometimes we are all the way around into the subintimal space, and when the dissection track is prolonged, I have seen the operators that they are doing the ballooning and left the dissection as a sort of investment procedure.
That is different. That is different.
Yeah.
See, if you want to enter the subintimal space deliberately, you puncture the proximal cap with some stiff wire like Gaia 3 or Confianza.
Yeah.
You nudge your cursor into it, and then you take a knuckle wire, which is usually Gladius or a Pilot. So the Gladius Mongo is better because it doesn't give you a big subintimal space. Then you knuckle down. Then you don't need to balloon anything. You can just take a stingray. But sometimes the cap is very ambiguous, where you can't penetrate the cap, or cap is not very, you're not sure where the cap is. Then if you want to dissect before the cap in the open part of the artery, then there is a technique called base, which is a balloon-assisted subintimal entry, which means you then take a 1:1 balloon to the vessel size. You keep a corsair behind with a ready to knuckle, and then you inflate the balloon. You deliberately dissect the artery before the occlusion, and then you knuckle down. So that is called balloon-assisted entry. Now, if you try to enter the subintimal space, true lumen, and you fail because either you can't enter, whatever, then some people do the ballooning so that the next time it's very easy to get into.
Okay, but my question is that in this subintimal space, once you are doing the ballooning, it must be 1:1, or
no, you don't have to do 1:1. The way I do it, I just take 2.5. The RCA, I just take 2.5. All you need to make room. So the next time when you come in, you can minimize the duration of that procedure.
Okay.
Yeah, but the problem is that if you create a too large space there, that it will be more difficult to re-enter. So yeah, 1:1 is really too much. Yeah.
Okay. So ideal anatomy for primary ADR procedure is using the cross post and the stingray system, and you need to see that there is a well-defined proximal cap, long CTO body, good distal landing zone, and no major side branches close to the landing zone, like in this case. Sometimes there is a development of intramural hematoma, and it leads to the compression of the distal landing zone. if the subintimal space is exposed to like a systemic blood flow. So what are the various ways how to avoid this intramural hematoma? I need to have your views about it.
Excuse me? We lost you for a few seconds.
There is sometimes intramural hematoma, and intramural hematoma is expanding, and sometimes it expands up beyond the distal cap and obstruct the distal vessel.
Yeah, this is a problem that I was saying. If you dilate too much proximally, the risk of having this big hematoma after the distal cap is there. And this can be an issue because there are collateral flows that may arise from there. So you should try to avoid it. Sometimes you can try to aspirate a little bit the hematoma with a microcatheter or with an over-the-wire balloon, but yeah.
So with the way I do is, if I were to do, one is definitely shouldn't balloon the subintimal space, especially if you want to re-enter. Second, if you can get a trap liner, with the trap liner is a balloon in the guide liner, which you can inflate so that the blood doesn't go into the subintimal space. And the third, something called a straw technique. Have you heard of it?
Yeah, straw technique. I have
straw
heard.
Technique is basically when you connect the stingray, before, of course, while you're going up into the artery, you take a 20 ml low lock syringe, you go negative, and then you put a clamp on the syringe so that it creates a super negative.
Okay, I see. Now, this is the one important point, if you can highlight, because there is a correct angiographic orientation of the stingray balloon. What I conclude from this diagram is that there are two positions of the stingray balloon, but you need to inline the X-ray beam, which is perpendicular relative to the stingray balloon. So balloon position should be like this. You can see the marker within the green, correct mark, wings overlapping and single line. So while using the stingray balloon, there must be X-ray beam, which must be oriented perpendicular relative to the stingray balloon, not opposite or end face relative to the stingray balloon. This is the point.
Okay.
So another very important point is that examples of different disease burdens at the landing position. The most rightward example is often amenable to re-entry within the stingray wire. Experienced operators are now using high penetration force wires for the scenario on the left. You see that as we're going from the right towards left, there is increased distal vessel disease burden and calcification. So most of the time when they are in the heavy disease burden, people mostly are using high penetration force wire to enter into the distal lumen. But at this stage, re-entry is very difficult. So these are one of the few cases which I have done in during my training, and this is a CTO RCA, and this is a long CTO, bifurcation CTO, and we used the dual catheters, and we all did the antegrade dissection and re-entry, and we are ending up with a mini crush bifurcation standing after opening the CTO. In this case, we use.
So you don't have the step-by-step analysis of this case, no?
Actually, I have a few videos that I will discuss this case later on, because this is one of the very problematic case, and we will discuss later with a critical thinking.
Okay, but come back to the previous one.
Yeah.
So my question, no, just one before. No, go ahead. Ahead. No, ahead.
Ahead.
Okay, keep this. So here, how much time did you spend in, no, go back.
Yeah.
How much time did you spend in trying to avoiding the, it's automatic.
In this CTO?
The knuckling and the ADR. So how much time did you spend in trying to do wiring escalation here?
In this CTO, we spent almost 4 hours.
No, okay. But when you see this type of CTO, how much time did you spend in trying to staying into the true lumen?
I recalled it is almost a 4 hours because it was a very long CTO I spent. And wire was firstly we tried all the way. Wire is in the subintimal space, both in the side branch and the
okay.
main.
So you tried a lot, but in the end
Yes.
you had to convert to an EDR. Okay.
Yeah.
And
yeah.
where did you re-enter?
Initially we re-enter into the very distal at this point, and we lost a side branch. Then we took another pilot 200 because it was a pilot 200 initially we have started. Then we tried with the second pilot 200 to enter into the side branch, but we were failed. And from this dissection track, then we did we took the Gaia third wire, and we then entered into the side branch.
Okay. Okay, thanks. Please go ahead.
This is another example which I have done just recently, about 1 month back. This is a whole RCA.
Wow.
It is also integrate dissection and re-entry, and there is one big plaque in the proximal RCA. Just trying to stop this. You can see like this.
Yeah.
So here I did the integrate dissection and re-entry, and we end up in the long metal jacket of the RCA in the end of the procedure.
Yeah. Okay.
So, what I am doing in my setup is that I am very, I have a good skills with the integrate dissection and re-entry and integrate escalations. But I am not using the Stingray cross-post because it is not available in our system.
Okay.
So for retrograde, I need to have some more advanced training right now.
Yeah, thanks. So which is your strategy for a wire escalation? Usually, do you have a series of wires that you use? You have the same escalation, or you change it according to the lesions, or you say, okay, I try one wire. If it's not working, I immediately cross to the ADR. How is your strategy?
My strategy is that we have a fielder XTA available in our setup. After fielder XTA, if I am in the subintimals, then I usually I have a strategy that if the distal track is very much clear to me, then I jump to always Gaia second or Gaia third. If the distal vessel course is very much clear to me, and there is provided that there is no side branch. If the distal vessel track is not very much clear to me, then if I am going blunt, then I usually take the pilot 200 to advance it. We do not have a Gladius Mongo available in our cath lab. And after that, if we want to puncture the CTO body, we have a CP6 and CP9 wire available. After this is what I am having in my inventory in my cath lab.
Okay, thanks. Thank you, Vakas. Are there questions?